We are calling this Choosing Radiology, so it's going to be a webinar on why you should become a radiologist and how to navigate this process. Certainly, there's going to be some changes to the process compared to how it was in the past. We hope to move through and hear from sort of all the key people that help make the residency and application process work. So we'll start with the chair's lectures. And then after the chairs get a chance to, talk with you a little bit about radiology, we'll give all of the attendees the opportunity to ask questions and talk directly with the chairs. After that, we'll move into a session where the program directors have some time to speak. So we'll hear from Dr. Spicer and Dr. Van Meter. And then again, we'll have a session where you can ask questions and hopefully we can have some interactive back and forth. Feel free as an attendee or as a panelist to, in the chat box, ask questions, and we may save up those questions as they arise and then ask them to the respective people during the Q&A session, or maybe if they're a simple question, one of the panelists can answer those questions in real time. Finally, we will finish with some information from the program coordinators about some of the unique challenges that come with applying to residency in this era of COVID-19. And as we move through the session, if we're moving a little faster than the schedule, that's fine. We'll just, take maybe a 5 to 10 minute break between sessions. And then at the end at 1 o'clock, I would encourage everyone to stay for speed mentoring sessions. So we are going to go into a separate Zoom meeting, and we have about 8 different radiologists who will all be available, and we'll be in small breakout rooms, maybe 3 to 4 students per room, where you'll get an opportunity to talk and ask questions in a more personal style. So with that, I will turn that over to Dr. Oates. I'm going to stop my screen share here, and I will allow her to take over the reins.
Okay, thanks, Joey. Can you hear me okay?
Yes, I can hear you very well.
Excellent. Well, first off, I'd like to just acknowledge the panel today of experts who are going to share their experiences with all of you, and to thank all of you for your interest in radiology and for joining us on this webinar and later on the speed mentoring. So I'd like to talk to you about is the diverse training options, diverse practice opportunities, and diverse careers that are available to you when you enter radiology. A quick disclosure, I am a trustee for the ABR, but what I'll talk about has really no bearing on the ABR, and so there really isn't a conflict. So let's start with the diverse training options. We have 2 specialties in radiology: diagnostic radiology and interventional radiology. Back in the day, we had tools, as you can see on this Swiss Army knife. But today, look at a plethora of tools we have. It's almost overwhelming how many tools we have in radiology today. So what is going to draw you into radiology, the pheromones as I've named them? Well, we have an essential role in healthcare. We influence decision-making for almost every patient, often multiple times in a particular patient. We consult with every other specialty. The multidisciplinary consultations are just part and parcel of what we do every day. So we are needed and respected by all other specialists. We use multiple modalities to perform image-guided procedures, and those are available to diagnostic radiologists, not just interventional radiologists. The non-vascular procedures, the more minor procedures, these are part and parcel of diagnostic radiology. The more advanced procedures are really what interventional radiologists do, as well as the minor procedures. And then what I'd like to mention, because this is my field, radiotheranostics, where we will do radioactive treatments based on diagnoses that we make with our imaging. So we do a diagnostic workup, then we treat the patient, and we follow up with diagnostic imaging and may or may not retreat with that same radioactive treatment. So diagnostic radiology or interventional radiology, what are they all about? Well, how does it work? And you'll hear more about this later. I'm giving an overview right now. So 4 years of diagnostic radiology, 5 years of integrated interventional radiology. And of course, these are after you've done a clinical year. You can enter interventional radiology from diagnostic radiology after you complete the diagnostic radiology residency by either doing 1 or 2 years. And you would do a year if you've done what's called the early specialization in interventional radiology pathway within your diagnostic radiology residency. Then you only need 1 year of a fellowship-like training. But if you haven't done the ESIR pathway, then there is available 2-year independent interventional radiology programs. So let's look at diagnostic radiology a little bit more detail. So I've mentioned the ESIR pathway already. There's also the 16-month pathway in nuclear radiology through the American Board of Radiology. And there are many fellowships in your senior year, and these vary, of course, from residency to residency. And it's something that you might want to look at as you consider various radiology residencies to apply to. After residency, there are a wide variety of traditional 1 to 2 year fellowships. And these fellowships are important for your subspecialty marketability and your career satisfaction. So let me just take a little side journey into the American Board of Radiology 16-month pathway, because that's, again, my field, and I have the podium, so to speak. So I'm going to entertain you with and inform you about this pathway. So in nuclear radiology, we have hybrid modalities of SPECT-CT and PET-CT, and this is an example of a combined or a hybrid modality of SPECT-CT that you can see in the upper corner. Again, as I've mentioned, we do radionuclide therapies or radioactive therapies, radioactive iodine, as well as intravenously administered therapies. And this pathway will give you the training to become a Nuclear Regulatory Commission authorized user for all therapies. And therapies are becoming more and more important today. There are more and more of them out there. You will become eligible for the American Board of Radiology subspecialty certification in nuclear radiology. And you can do a traditional fellowship after you graduate from the diagnostic radiology residency, because this 16-month pathway is embedded within the 4 years of diagnostic radiology. And this will increase your marketability if you have 2 subspecialties, 2 fields that you can be an expert in your practice setting, whether it be private or academic. Here's just a quick update on where we stand with the ABR 16-month nuclear radiology pathway. We've had, just in a few years, it's just a little older than 3 years at this point, and more than 100 enrollees. UK has graduated 1 16-month pathway participant, and 2 seniors are in the pipeline to graduate this year. And about a third of the radiology residencies, diagnostic radiology residencies, are participating. And there actually is 1 interventional radiology program participating. So it's really taken off. So I'm going to give a little bit of a taste of nuclear radiology. So if you like dynamic physiology or pathophysiology, you can see 2 hepatobiliary scans here. This is a normal scan, and this is a bioleak. If you like integrating function and physiology with anatomy and pathology, you can see metastatic breast cancer on this PET-CT. If you like color, we live in a world of color. This is a GI bleeding scan. This is an active cecal bleed in the right lower quadrant. If you like seeing the whole body in a single image, this is a skeletal scan, bone scan. And this is a patient who had an osteosarcoma removed, so you can see a cold region in the tibia, and also had exercised his biceps muscle, so we do see soft tissue activity that I'm showing with the arrows. If you like applying unique biodistribution of a wide variety of diagnostic and therapeutic radiopharmaceuticals, the radiotheranostics, as I mentioned earlier, you can see, and you like 3D imaging, three-dimensional imaging, you can see here on this radioiodine scan that we have recurrent thyroid cancer in the mediastinum. That's a coronal slice from a hybrid SPECT-CT image. The CT and the nuclear fused together. If you like evaluating a wide variety of organ systems and diseases from head to toe, this is a parathyroid scan, and you can see here that there's a deep parathyroid, hypercellular parathyroid gland that has been causing this patient problems with hyperparathyroidism, and we've identified it and localized it for the surgeon. So if you like all of those things, then nuclear radiology is for you. So now let me get back. Our side journey is over, and now we're getting back into the rest of diagnostic radiology residency. The ESIR pathway that I mentioned earlier, the interventional pathway embedded within the DR residency, requires 12 months, as shown here, a certain number of procedures, and then you would have, if you complete the ESIR pathway in your DR residency, then you would be eligible for advanced placement and do 1 year of independent IR residency, akin to a fellowship. It's called a residency, but it's akin to a fellowship. So let's talk about mini fellowships. Well, the ACGME allows up to 16 months in a single discipline or subspecialty within your diagnostic radiology residency. There are program-specific options. Again, I would encourage you to ask in the various programs that you are interested in and that you interview at. Usually these mini fellowships are in the senior year. They don't have to be, but that's usually when they occur after the ABR core exam is taken at the end of the third year. One thing to note is that these mini fellowships do not give you eligibility for subspecialty certification through the American Board of Radiology. And they help you to prepare for a traditional fellowship in that same discipline, or they let you delve more deeply into other disciplines that you are not going to do a fellowship in, but you're interested in. So now let's look at the traditional one-year fellowships in diagnostic radiology. And it's a little daunting, so I'm color coding it here. And again, these slides can be available to you after. But there are 5 ACGME accredited programs, and 2 of them are on a match, as you can see, and 3 of them lead to ABR subspecialty certification, as you can see in the blue. There are many non-ACGME accredited programs out there, many. I'm just showing 4 different names of fellowships that you might be interested in your future: body imaging, chest imaging, breast imaging. And breast imaging is actually on a match, and then women's imaging. These are just examples of non-ACGME accredited fellowships that are out there for you. So now let's look at practice opportunities. So again, there's a lot of diversity in what we do every day. We oversee all kinds of radiologic imaging therapies. We perform a whole range of procedures. And this is some data from the American College of Radiology, which is our college. 84% of practitioners are full-time in radiology. 68% of the practices actually have a part-time person or 2 or 3, and 23% of the practitioners are women. So it is still a male-dominated field. And, you know, we're trying to change that, but it is still at this point mostly men in the practice. And you can see here the workforce trends by practice type. And the ACR does a survey every year, and you can see from 2012 the trends. Most practitioners, most graduates of radiology residencies and fellowships will end up in private practice, about 50%, as you can see. It's more or less stable over time. And then you can see that academic or university-based practices come in second, and you can see the other trends. So the ACR survey in 2019 showed that the hiring projections were somewhere on the order of 800 to 1,800 new radiologists. We graduate about 1,300 a year. So there is a good chance you will get a job when you graduate. The most projected hires as of 2019 were in breast neuroradiology and interventional radiology. These do change year to year. one thing that I really want to convey to you here is this third, bullet point here. Only 7% of first-time hires out of training, which would be your group in a few years when you finish your training, had no fellowship. So in other words, the vast majority, 93%, had a fellowship. So I would encourage you to strongly consider a fellowship. So a clinical year, a DR or IR residency, and if you do DR, then you would do a fellowship after that. One thing for job security for all of you, since you're starting out, again, the last bullet point here, it doesn't have a bullet, but the last point on the slide, 8% of the workforce is greater than 65 years of age. So this is an aging workforce. And 22% of those out there working are in the pre-retirement years. They're aged 56 to 65. So when you graduate, you will definitely have a job available for you. There is no question about that. So you want to do a fellowship, and you will have job security if you go into a radiological field. So now let's talk quickly about diverse careers. And this is a day in the life, and this was suggested to me by one of my radiology residents that I put this in for you. What do we do every day? We solve problems, we apply our knowledge, our skills. We are looking at all the imaging quality and patient safety. We are directing the radiological care, if you will, of patients every day. We are also a hub for research. We have all kinds of tools, as I mentioned earlier. You can really help the various specialties in their research. We have biomarkers, we have phenotyping based on our anatomical and physiologic imaging. It's just a rich opportunity there. We do have high volume. Don't mean to scare you with that. We do have great variety. I hope that's a draw. And we are never bored, and I hope that is a super draw, because every day is different and every day is exciting. I personally have great satisfaction at the end of every day. I feel fortunate I made the right choice for my specialty of diagnostic radiology and my subspecialty of nuclear radiology, and I love radiology, and I hope you will too. Happy to answer questions later in the session. Thank you.
All right, Dr. Oates, thank you very much for that talk. Dr. Contractor, I will turn the screen over to you and let you talk. If you have slides, we can do that. If you are just speaking, either way works for me. Do you have something to share?
Well, I have something to share, but not on the slideshow.
Okay, perfect. So what I'll do is I will spotlight your video so that you should be the main video up on the screen for everyone to see.
Okay. Well, good morning, all of you. Thanks for having me on here to the folks organizing this. I recently started as chair of radiology at Louisville. I came from New Jersey, Rutgers, where I was the chair and spent 15 years there. So this is certainly new, territory, but at least geographically. But what's not new is, is sort of mentoring students and residents over the past 15 to 17 years. I've been very involved in the SIR early career section and the RFS sections. And I strongly encourage, folks that are looking at a career in IR or DR to be involved in the society's, early career sections, because that's a lot of resource over there and a lot of peer mentoring that goes on in those places. So before I go on, thank you, Dr. Oates. I mean, that was a fantastic, overview of the different tracks and different sort of guide, pathways into radiology. What I traditionally, tell my trainees and students is really, when you're looking at your career options, you need to define, first of all, the why, right? I mean, that's really the most important factor of why you should be even on this, Zoom call, first of all, and what it is that you are looking to do with the rest of your career. That why is also a question I ask, almost all the applicants that are interviewing. And if that why happens to be, it's a great lifestyle and I'll make a lot of money, but I can tell you, you're going to be at the bottom of that rank list that we'll be creating. So that can't be the why. I mean, the whys certainly need to be that it's a clinically driven, specialty, not just IR, but also DR. I mean, the number of times that that clinical decisions have been changed with that just one consultation with a diagnostic radiologist, and the impact it has on patient care, it's absolutely immense. So you need to understand that you're not entering radiology as a paramedical provider, but you're right in there. In fact, CMS, despite all of us being hailed as heroes, in this healthcare thing, CMS is now proposing a close to 10% cut for radiological services, and except for primary care. And there's a big move by our societies to include us as a primary care service. And that really, if you have been in the ED or been on the floors and seen the number of times radiology has impacted clinical care, um, it's no secret that the art of physical examination, the art of real patient discussion is a dying art. A lot of it is based on analytics and numbers and images, and it's no secret, right? I mean, you can't argue with a pathologist when they come back with a report that the potassium is 7.0. I mean, there's just no arguing with that. Just like that, there's no arguing that there's a pneumothorax on the chest X-ray. I mean, the clinician can tell you all they want about how the ear breath sounds on that side, but if there's a pneumothorax, there's a pneumothorax, and that just changes everything. So the why is really important, whether it's the intricate clinical care that you're going to be involved in, not just again in interventional, but also in diagnostic. Your really desire to be part of a multidisciplinary group team. I mean, we see more and more this concept that it's really teamwork that makes the dream work, right? And then radiology is really part of that big team, and we've got to sort of embed ourselves in that team. So if you are a pulmonary radiologist, a chest radiologist, you need to have all the ICU and all the pulmonologist numbers on your cell phone, and likewise they need to have your number on, because that's really what it's all about, right? I mean, as an interventionist, I can tell you all my clinical referrers, in the past 2 months now, we are on first name basis, and we've got each other's cell phones. So really being part of a dynamic team is sort of key. um, the work style, the work scenarios, those are all changing. I mean, in fact, I can tell you that we as radiologists are the pioneers of telemedicine, right? I mean, if we had not invented teleradiology, the whole world would have collapsed now, because there would have been no telemedicine. So that's, again, if you can see the impact of what we've done over the past 25 years. I mean, Dr. Oates and me, grew up when we went to, maybe I did, but we trained on having X-ray films, and that's not there anymore. And again, this is something we've taught the world. So we are really dynamic leaders in technology, and that's sort of a given fact, right? I mean, we deal with technology, so it's really important for us to adopt those technologies, which brings me on to what I term as algorithm-based care, and some people call AI in healthcare. Um, I think that's going to be the biggest opportunity coming down to us in the next 10-15 years. And I know it sounds pretty remote, but I can tell you 20 years ago, none of us held iPhones in our hand, none of us could monitor our heart rates on our phones, and now we can. So it's only a matter of time before a computer scientist, or many of them, discover what we are doing as part of our mundane tasks. um, Recent changes in the way we practice radiology. Dr. Oates touched upon some of that. I'll give the flip side of the 93% that need to do fellowship. I think that's a challenge, to our graduates, because that just means that 93% of those folks are not able to find a job right out of their residency, which could be true, because most practices, are sort of saturated in a lot of specialties, and where you find your niche is going to be really key, and you can't predict what is going to be the dominant job market 8 years from now. So I would strongly recommend you go into radiology with an open mind, and look at all the specialties, rotate through the reading rooms, through the IR rooms, and then really decide, make an informed decision of why you want to do a certain subspecialty. You may be telling yourself you want to do IR, but hey, your first rotation and you really don't like it. So keep that open mind. Which I just want to tangent off into the DRI Art tract, and that, is or was the most popular residency when it did come out. It's starting to taper down a little bit now. In fact, the first year it came out, it was even, more competitive than neurosurgery, if that has any, bearing on what you might be doing. So it's pretty intense to match into a good spot. Things that you should be looking at in terms of preparation, if, and granted, these past 6 months have probably waylaid a lot of your plans to sort of put your research projects and put your, shadowing opportunities, to the wayside. But things that you should be doing. So what we look for when we try to match somebody is really the passion for why you want to do IR, and you've got to present that passion through, whether it's through, the time you spent with a mentor or with a research project, or in general knowing about the specialty. So I like to, have applicants come in and tell me what it is that they think are the biggest challenges that have faced IR, where the biggest, opportunities have been, where they see fitting in, who they see as their role models, mentors, what they think the limitations of some of us are in practice. I mean, so I like to have that sort of discussion with my students, student applicants. So in the DRIR tract also, I don't know how it's going to pan out. This is the first year we're going to have graduates coming out. Now, again, most jobs in the US are private practice jobs, and most, positions require you to do maybe 60, 70% IR and some DR. And I'm not quite sure if those DRIR graduates now are going to be ready for that, because the last 2 years are spent in IR. So that's certainly something that, you might want to consider as you're looking at this, is how do I structure my DRIR residency so that if asked to do diagnostic, I'm able to do diagnostic. And I think that's going to be a big, issue with folks. I'm actually recruiting somebody who's done DRIR, and they don't feel quite confident that they could, if needed, do diagnostic radiology if asked to. So, maybe a little challenge as you think about it. From past experience in folks applying to DRIR from my program in Rutgers, typically, people apply to about 25, 30, get interviewed at about 15, 10, and end up ranking, all of them, and then they end up matching either their first, second, third, fourth spot. So depending upon how competitive your CV is and how, good your interview goes. And this is going to be a little challenge with the interview, because it's all going to be online, so a little hard to sort of portray that subtle human element of being able to work together, I think. So we'll see how that goes. But really, so those are some background things that I can think of. I'll be certainly open to answering questions that the participants have. So, feel free.
Just to start off the questions, and then we'll see if any attendee has a question, feel free to raise your hand, and then I can, unmute your microphone so you can ask the question directly, or feel free to ask the question in the chat. But one thing I know that comes up a lot with medical students and people interested in IR, and I'll direct this to you, Dr. Contractor, since you brought it up, is this AI. And I think there's a misperception that artificial intelligence is a threat to radiology.
Yeah.
And I really think that it's the complete opposite. It's a huge opportunity. And could you just speak a little bit more about your perception on how AI might shape radiology as we move into the future?
Yeah. So like I said, it's probably the biggest opportunity we have in radiology now to adopt and to implement it, right? Someone said that AI will not replace radiology, but it will certainly replace the radiologist that does not adopt it. So we have to have it. At present time, I think there are 10 or 11 FDA approved AI algorithms that, again, these are limited to identification of an abnormality. So for instance, there's an algorithm to identify a pulmonary embolus, and what it really does is it just prioritizes that study to the top of the list. So if you've got an outpatient center that has 50 studies, and they're just all following a sequential time order, and study number 49 has a tiny PE, on it because it's from the cancer center and they could have PEs, that study will just get, prioritized up to the top of your list. So you won't miss it, and you'll read it faster. Again, AI is thrown as this also be all end all, and I don't think it's going to be there, because if you look at it, each unique disease entity needs to have an algorithm built, for it. So just like PE has an algorithm, pneumonia has an algorithm, intracranial bleeds have an algorithm. So if you're going to look at, doing that, then you're going to need to have an algorithm for, for extraaxial bleeds, for brain tumors, for skull fractures, for mandibular fractures. And that's going to take a whole lot of time, and probably will not happen, in the generation that we are speaking to right now. I think it might happen 100 years from now, because guess what? Last century, everybody rode horses and the privileged drove cars, and today everybody drives cars and the privileged ride horses. So things change. But I think AI is the biggest opportunity we have, and I think we need to have folks that have the interest, passion, training, background. And I mean, I don't have any background, but I certainly have read a lot about it and gotten myself accustomed to a lot of the technical parlance that goes with it. So all applicants over here, I think you need to, if you don't have an engineering background, I think you should really look at educating yourself in that.
And still haven't seen any questions from the panelists, but for you, Dr. Oates, you had touched on radiology having, certainly a higher proportion of men than women in the field. How do you think we are working to address that as a specialty in radiology? And what would you say to somebody who might be hesitant to go into a field that has a higher proportion? So women interested in radiology, why would you encourage them to still pursue radiology and overcome any challenges they might face?
Well, it's a good question. I don't know if I have enough time to fully answer it because of the whole discussion, but I think that if women are on the webinar, and I hope there are women on the webinar, radiology is definitely a field that you want to pursue. There is a lot of opportunity for women, and because it's male dominated, and this may be counterintuitive, but the opportunities are even greater for women because there aren't as many women. So women who go into radiology will be able to forge their careers in successful ways today. Of course, there are certain subspecialties within radiology that are more attractive to women. For example, breast imaging or women's imaging. I mentioned those as fellowships. But women can do every subspecialty. They can do interventional radiology, and a lot of the leaders in the field in interventional radiology are women. So even though, again, there are fewer women in radiology, the women that do go into it, such as myself, can forge very successful careers if they want to. Also, radiology does allow different, and Dr. Contractor touched on this with the teleradiology, it does allow for different work environments or different work styles, work life. So that whole idea of work-life balance is achievable in radiology, and that might be attractive to women more than they might realize. So I want them to think about that, although it's attractive to men as well, to have opportunity for remote work or part-time work. So lots of opportunity for women. And the fear of radiation, let me just address that just to get it out of the way. Years ago, that might have been a real concern just because equipment was not as good as it is today, or the self-protection was not as good as it is today. Just one example from my own life. When I was in training, and you can't see my whole body, but I'm kind of small, short, So I had to wear these lead aprons that were so massive. They were like football player size lead aprons. And so when I was doing any kind of fluoroscopy or or interventional radiology work or whatever, I had this massive lead apron on because we did not have custom fitted aprons. Today, at least, I think most radiologists can have a custom fitted apron that really fits in maybe a two-piece apron with a vest and a skirt, a wraparound, and it wraps around as well. It covers your back as well as your sides, and a thyroid shield, and then glasses. So, I mean, today we're able to protect ourselves so much better than in the quote old days. And technology is so much better. The ability to have limited radiation is, so I don't think anyone should be afraid of radiation, man or woman. Nobody should be afraid of radiation. Cautious of it, aware of it, but, not afraid of it.
And then I guess another question, and that, I think in academic radiology, we're all pretty aware of, but maybe the students aren't aware of, just touching back on the job market, I would say that's always something in the minds of students. Am I going to be able to get a job? And I know at least at University of Kentucky, and I would say at Louisville, there is great demand, both in private practice in our community and in academic radiology for additional radiologists. And can you talk about how either Dr. Contractor or Dr. Oates talk about what demand you guys have for radiologists currently, and how much demand you might see over the next 5 years? And either one of you can speak.
I'll just start because I touched on that in the talk of the data from the American College of Radiology. Yes, we have multiple positions available. Why do we have positions available? It's mostly because we're expanding, we're growing. The need for radiologists is increasing. And as the American College of Radiology shows, there is a market for radiologists to replace retiring radiologists, but to also just fill the need that is continuing to expand. The demand for radiologists, I don't think, has ever been greater than today. And so I think anyone who goes into the field, I'd like to hire you today if I could, but I have to wait for you. The pipeline is a long pipeline. And that's a little frustrating from my perspective because I have to wait so many years for you, the applicant who's on the webinar today, to complete your training, to hire you. But I don't think it's ever been better. And again, the opportunities for just a very satisfying career, a very rich career, again, I don't think have ever been better. But I'll let Dr. Contractor weigh in on his opinion.
Well, thanks. Yeah, look, I think it's all demand and supply, and I think as you're evaluating going into a specialty or not, that's going to go up and down. But I think as long as the underlying premise of the U.S. medical system, which is volume-based care, persists, I think we'll have enough jobs going around. I know I can find enough people, to staff my department. We are using or overusing our teleradiology providers, and it's not good, although they are now the biggest employers of radiologists in the country. So I don't know if you've heard, but Radiology Partners was the biggest, and now it's become even bigger because they acquired VRAD. So, the demand is massive, and that's fueled by, the clinical desire to image, everybody, not once, not twice, but as many times as they can. And as long as that holds true, I think the demand will be there. So the supply is limited. I'll just go back to the previous question, Dr. Owen, if you don't mind, is I've had these discussions with my, female colleagues, on many occasions as to really what is it, and Dr. Oates touched on some aspect of it, what is it that sort of restricts or prevents, or what are the barriers to entry, for a female medical student to, to pursue radiology? And I don't know what the other panelists sort of, have on this, because I see, some women on here. It'll be interesting and very helpful, to sort of address those. I think that the issue about radiation exposure she touched on, I think that was a fair sort of concern, but it really is not a valid concern anymore, as she alluded to. So I don't know if there are other barriers to entry. It doesn't help that most chairs also are males, and and maybe there is some bias on that, and I'll and we sort of consciously and actively try to eliminate that bias. But what else limits a student from thinking about it? Maybe let's see what the panel has, or maybe the students on this thing have some concerns.
Yeah, one thing that's been shown in the past is that physics scares some women away, which it really shouldn't. Okay, so do not be afraid of the physics, please do not. I could handle it, anyone can handle it. Okay.
Me too.
All right, so we do have a question here from Madison Crank, and they said that they really just made their decision to pursue radiology quite recently, and they're very passionate about procedures and sort of can see themselves as an interventionalist, but because they've made this decision pretty recently, would you recommend them pursuing DR initially with the eventual potential to go into IR, or trying to directly go into IR, even though you may not see yourself being a diagnostic radiologist? That Madison conceives of themselves as being an interventionalist.
Yeah, I can take that for Madison. I mean, again, as I stated earlier, I think it's the passion that you bring to your application that is going to make that difference between whether you do get ranked or not. The fact that you have not decided so far is not a big deal, because nobody was born to do IR or DR. That's a matter of training. So if you haven't had much exposure, but you do realize with the limited exposure that that's something that you really want to do, I think that's what will come down to. In terms of going the DR versus DRIR route, I think that's a more of a personal thing. If you're kind of still tentative about doing IR, then I would go with the DR route, because at this point there are enough independent IR fellowships around, and they are likely to stay, and they might even increase. Just like we've added a spot this year, other institutions are looking at adding spots. So I think pursuing DR initially might not be a bad option.
Yeah, and if I can just weigh in on that, I'm not sure why it's not showing me as I'm talking, Joey, but is that multiple So multiple subspecialties have procedures within them. So just as an example, musculoskeletal radiology has quite a few procedures that are part and parcel of the field. And so I think, and abdominal radiology has a lot of procedures. So I think as a diagnostic radiologist, you can do what is sometimes termed IR light, the non-vascular procedures, or even some, limited vascular procedures. You don't have to be an interventional radiologist who's fellowship trained or residency trained in IR, who is more suited for the more advanced work. So there's a lot of procedural work that is embedded within diagnostic radiology, and I think that's important to bear in mind. And one thing, and maybe, Dr. Contractor, I don't mean to put you on the spot here, but I think one of the advantages to me of having the DR background and keep your hand in DR is that if you're injured or for some reason physically become unable to do the interventional work, the intense interventional work, you have DR to fall back on. So I think keeping your hand in DR is probably a good strategy, but maybe you can comment on that.
Yeah, absolutely. Like, I think I did sort of allude to it earlier, is that the DRIR programs might limit your ability to do diagnostic at some point in the future, because the last 2 years of your training are really spent in IR. And I grew up in the diagnostic world. I did my sort of standard training, going into a fellowship after residency. And I don't think I was badly trained, as an interventionist. So I don't think it's a bad option.
And just from a little bit of my perspective, I thought almost certainly I wanted to do IR. Back when I applied to radiology, there was the direct pathway, and I looked into that, and I didn't pursue the direct pathway, but I ended up thinking I would only do IR, but loved DR. And I still love procedures, and I love doing procedures, but I also love DR, and it's hard to know how much you're going to love that diagnostic part of it until you really get an opportunity to train and learn and be exposed to it in a more work environment. We had another good question here, and it says that we had addressed how AI may influence the future of radiology, but another issue that's been brought up by people to this particular student was the concern for outsourcing radiology work to other countries or other time zones. And they want to hear sort of what your all's thoughts are on that impact for, say, the job market or the demand or desirability for radiology.
Okay, well, I don't mind starting. I think that most radiology in this country is done by radiologists in this country, but they might be in a different time zone. They might be working in Hawaii and, doing a case from Boston or something, because of just time zones. But again, and Dr. Contractor mentioned this earlier, that teleradiology companies are a big employer of radiologists, but then again, I think on-site radiologists who are actually in practices and who have the ability to interact with the referring community, as we've discussed, and really are part of a care team, that is still incredibly valuable. So I think you're always going to have a balance. A lot of the teleradiology work is during what I call the off hours, which is in the evenings or nights, maybe even weekends in some practices. But I think there's a mixture of on-site radiologists who are part of a practice and the teleradiologist to cover, because we're 24/7. The reality is, for any hospital-based radiology group, whether it's academic or private, a community hospital, rural, urban, it doesn't matter. You're 24/7. So if you as the radiologist in the group cannot be present at 3 a.m. or isn't available to be awakened at 3 a.m., then you need someone who is available, and that is often a teleradiologist. So it really just depends on, exactly where you are. There are, for example, at UK, we do have 24/7 on-site radiologists. We have an emergency radiology division that is available during the nighttime hours, really 24/7, because, but they're there at night. So we do not need to outsource any imaging on our patients during the evening or nights or weekends, because we are there. We, the UK radiologists, are available. But depending on where you are and depending on the kind of practice, teleradiologists will be needed, but most will be US citizens. They just might be working in US based is what I meant to say. They might just be in Hawaii because you're trying to cover those hours and taking advantage of time zones.
Sorry, I was muted. So we do use, some teleradiology providers, and they are helpful. So yes, they do get farmed out, but I can tell you over the past 20 years of teleradiology, I think Medicare has come up with laws that state that you have to be a licensed provider within the, territorial United States to be able to bill and collect on a patient. So, there are overseas and not just overseas, but international firms that do provide teleradiology services, and they may be providing some level of preliminary reports, which is valuable, because if you're in a small, rural place in the middle of, Kentucky, then, somebody has to read those studies, right? So patient care has to go on, as Dr. Oates says, and it really just comes down to supply and demand.
right. Let's see. So I'll give just another minute if there's any other questions. We're kind of approaching that 11 o'clock hour when we're going to start to hear from Dr. Spicer and Dr. Van Meter. So any last questions? Or
I just have a question for you, Joey. How many are on the webinar? How many students have logged into the webinar?
There are 25 students that have logged
Good.
into the.
Okay, so
there's been a little bit of change back and forth.
Okay, good. So again, to those 25 who are on the webinar, I hope you go into radiology. It's a great field.
All right. Yeah, I mean, I guess certainly all of us, I think, who are on the panel are very passionate about radiology, and we're all very happy that we chose this specialty. And certainly we hope you can sense that passion, and we'll keep on, and hopefully in the next session, we'll start to get a little bit more into the logistics of applying to radiology and what the different programs are looking for in terms of applications, and what kind of things you can try to do to prepare yourself to be a successful applicant. So any last questions before we start to move on? It looks like both Dr. Spicer and Dr. Van Meter are on.
Before I go, I just have my email and phone number on the chat. So if anybody would like to reach over, you're welcome to. Happy to answer any questions, either by email or on a phone call. So
yeah, and I guess thank you for that contact information. I also would like to encourage all the attendees to really feel free to communicate with anyone that you're seeing here on the panel today by email. Or by phone. All of us are very accommodating, welcoming. We want to talk with you. We want to communicate. So don't feel like you're ever bothering anybody or being in imposition. Certainly reach out to us by email, by phone, whatever your preferred contact is. We'd love to talk with you more about radiology and answer any questions that may arise after this webinar is over as well.
Yep.
So with that, we can say thank you very much, Dr. Contractor. Thank you, Dr. Oates. We really appreciate your time this morning, and those were great presentations. I think you addressed a lot of these high-level issues that applicants might have when trying to decide whether or not they want to pursue radiology. So I appreciate your time and the effort you put in this morning. And hopefully it was very informative for the attendees.
Thank you.
Thank you.
All right, with that, we're going to move on to the next session. And I guess we can start. Since we started with Dr. Oates, Dr. Van Meter, would you like to, are you available to start and give your comments and questions?
Certainly. Can you hear me?
I can hear you.
Yeah.
Yes, absolutely.
Okay. Well, welcome to everyone who is attending today. I'm the program director for Diagnostic Radiology at the University of Louisville. And today, myself and Dr. Spicer are going to kind of go over a little bit of information.
Oh, I'm sorry. I just muted you. I'm sorry. Can you unmute? Sorry about that.
Did that work? Okay.
I'm sorry.
So we're going to go over today some things about the application itself and what we look for in applicants, and any questions that you have, please. We're doing it through the chat, correct?
Yeah, we're accepting questions through the chat, and then I'm presenting them. Although the students, if they wish to raise their hand and talk directly, that is a possibility as well.
Okay, sounds good. The application process itself is obviously a little different this year, as we won't be able to view your application until October 21st. My suggestion to all applicants is to make sure that that application is in and complete by that day, so that we can view your applications on that date. If you turn your application in later, then it's time-stamped the later date. And then you always just want to make sure everything is in and on time. You always want to make sure that your application, when you do turn it in, that it is complete. You have your, what you need. Sometimes letters of recommendation will trickle in a little bit later, and that's obviously okay. We understand that. But just to make sure your USMLE scores, your transcript, everything else on your end is there on October 21st. I can speak for my program. In terms of letters of recommendation, we require 3 and 1 from radiology. If you have more, then that's also fine. But from my standpoint, what I'm looking for is letter writers of those attendings that know you the best, that know you well. It's always better to have a letter of recommendation that is more meaningful than for one that is just a name. Because I read all of the letters of recommendation, and I feel like that gives us good insight into what kind of applicant that you are from others. Other things on your application, personal statements, those are a little bit tough. They're difficult to write, but putting a little bit of thought into your personal statements. The personal statements that I like best to read are ones that are, in fact, very personal. Typical questions on interviews, we always kind of like to know why you're going into radiology. And a lot of students like to address that in their personal statement, which is fine. But having a personal statement that is more personal, that tells me something about you that I wouldn't otherwise know, just reading your application is always a good idea. And that in turn will give us some talking point during the interview to chat about. And those are the ones that I enjoy reading the most. Now, in terms of overall application, step scores are obviously important. And the reason those are important is that radiology is a very challenging residency. The board exams are difficult, and we want to make sure that all of our residents in our programs are going to be successful, because that is the goal, is to train very competent and confident radiologists, so that at the end of your training, you are board certified. And so step 1 scores are important. However, it's not the end all be all. We like to look at the total package. The step score is obviously something that is important, but someone who is well-rounded, that shows leadership, that has other activities, an applicant that isn't just good at being a medical student, but good at being an overall person in the community is always nice. Research is something that we look at, but it's also not the end all be all. I like to see residents involved in research. It shows that you have an interest, again, in other things than just being a medical student, and it gives you a more broader perspective on medicine in general. But again, sometimes radiology research isn't always available at your institution. And if you have research in another field, that is not certainly counted against you. So that's kind of what I look for when I go through an application. And I think that's about it for me. Dr. Spicer, do you have any comments?
Just whenever you're done, Tracy.
Yeah.
Sounds like she's good. You want to
Okay.
start?
All right, you hear me okay?
Yes.
Okay. Let me turn my video on. Sorry about that. Okay. So I'm going to talk about 3 different questions, and Tracy touched on some of it, but I'll kind of give you, I guess, my take on some of this as well. And so the first thing I'll talk about is how to strengthen your application, and then I'll talk briefly about what I'm looking for in an applicant. And then I'll talk about some things that maybe are challenges with COVID and how you may address some of those issues. So as far as how to strengthen your application, it obviously depends on what level you're at right now. If you're a first year med student here today listening to us talk, my advice to you would simply be just focus on your grades and the material that you're learning in school and do as well as you can in the classes. And probably from the first year, the thing that's most applicable to us in radiology is the anatomy, and you really want to learn the anatomy well. I guess if I had to pick a second thing, it would be the physiology. So I would really try to focus on those things in the first year. The summer between the first and second year, you may want to involve yourself in some type of research project. If it's in radiology, great. If not, well, we understand that may or may not be possible. But if you want to go into research, into radiology, then doing radiology research would be beneficial. Again, in the second year, again, focus on your grades. You really want to do as well as you can to get yourself ready to take step one. I believe this is the first class that the M1s will be taking the pass-fail step one, as opposed to the traditional scoring system step one. But regardless, you want to do as well as you can. And then other things you can do during the first 2 years are get involved in some extracurricular activities, so you can add some of that stuff to your CV once you're applying for residency, so that it doesn't look like you simply just went to school. You have some other things on your CV that you can discuss. The summer after your M2 year, obviously, is when you're going to take step one. So you want to do as well as possible on that. Going into the M3 year, you really want to focus on doing well on the rotations, and for multiple reasons. One, to learn the material and learn patient care, but two, so that you can refer back later to get a good letter of recommendation from somebody that you worked with. And also to help prepare you for step two. For our program in particular, the rotations we look at most closely to see how you did, and the comments for those rotations are the surgery and the internal medicine rotation. So we really would like to see that you did very well on those two rotations in particular. The M4 year, traditionally you take step two early in the M4 year. So you want to prepare and do well on that. And then all the stuff that you did in the third year, similar, keep trying to do well on rotations, score well, and all those sort of things. So that's sort of a general gist of like what you want to be doing during medical school to have a strong application for residency. So then what do I specifically look for? The answer to this question, honestly, is every single person that interviews you is going to have a different set of things they look for. And they will have different priorities as to what they consider is most important. So even between me and Dr. Lee and Dr. Owen, who are the three from our program today, we all three value different things slightly. And I'm sure Dr. Van Meter values some different things as well. But in general, this is what people look for. You have to have a baseline level of grades and step scores. What people consider their baseline is different. Some people's baseline is going to be higher than others for what they want to see for those scores and those grades. But generally speaking, obviously, if you failed a step, that's a bad thing. If you have failed a class in med school, that's a bad thing. So if those are the cases, it doesn't mean you can't get into radiology. It just means you really need to have shown a lot of improvement since that happened and have an explanation for it. But generally, we want to see, that you have done well in school and done well on your scores on your tests. A general number is if you've scored national average or above on the steps, you're probably in a pretty good competitive position to match into radiology. If you scored lower than that, you still may be competitive. But obviously, if you scored higher than national average, you're going to probably be fairly competitive. Class rank and grading, again, if you're in the top 2 quartiles or the top half of your class, you're probably fairly competitive, but not to say that people that score lower are still competitive. There are plenty of people that are in the 3rd quartile, but then they do really well on the steps for whatever reason. And so all that kind of balances out. So don't don't panic, you know, if your score isn't what you want or your grades aren't what you want. That's the situation when you need to actually maybe come talk to one of us individually to see how competitive you truly are and how to proceed. But for me personally, and maybe for other people as well, the grades and all that are nice, and you need to have a certain baseline of grades and test scores, but I look a lot at the person. I try to get a feel for their personality. Are you somebody that I want to sit with and work with? Are you somebody that I really want to mentor and want to see grow? Or are you somebody that's just going to annoy me? So if you're likable, if you're pleasant to be around, that's a real plus. If you're a teachable person, that is a real plus. If I perceive that you're not teachable, then you're probably not somebody that's really going to thrive with us, because you're just going to butt heads with people all the time. We want somebody that's a hard worker, and the more that I perceive that you're a hard worker, the lower I might consider your scores and your grades, because you may be able to push through it just because you're willing to work really hard. I want somebody that's conscientious about patient care, you know, that they'll pay attention to the little things. They'll make sure that their dictations are correct. They have the correct information in it. If they go do a procedure, they'll actually do the consent correctly. They'll pull the line out correctly, all those things. You know, somebody that's conscientious and actually cares about other people instead of just caring about themselves. And then finally, somebody that's self-motivated. Radiology, like Dr. Van Meter mentioned, is a specialty that you really have to study a lot, and you have to go home and you have to do a lot of work yourself at home. And I can't go home with you and make you do that. So we want people that are self-motivated, that will actually do those things without us pushing them or prodding them to do it. So those are some things from a personality standpoint that we try to tease out to see, are you somebody that, you know, can fit and really thrive in radiology? And then the last thing is COVID. COVID may present a few unique challenges, but overall the application process and everything is going to be quite similar to what it normally is. The difference is the interview itself. So the issue is going to be, for you as the applicant, it's going to be harder to get kind of a gut feel for a program. You're not going to be able to go to the city to get a feel for the city, where the hospital sits within the city. You're not going to be able to actually see the people in person, tour the hospital in person, all those kind of things that you might like to kind of get a feel for, to see if you can envision yourself being there. And the same for us as the program. We can't see you in person. We can't see your body language as well. We can't get kind of a vibe for you. So it's kind of going to be difficult on both ends. So what are some things that maybe you can do to kind of help overcome that from your end? I think you really need to be more diligent about looking at the websites up front to see what that program offers, and to get yourself prepared for the interview. So that you can actually ask intelligent questions at the interview instead of more of the superficial questions that you ask everywhere. You need to decide what's truly important to you when you go to an interview. For some people, it's geography. They really want to live in a certain part of the country, and the program itself is important, but secondary to where the program is located. So if geography is what is important to you, you need to figure that out. If you're really more interested in the quality of the training in the program, then that's a different story. And so you need to investigate what are the programs that are the top fits for you. You have to be honest about how good of an applicant you are relative to how good the programs are, and what is the proper match that you could realistically expect to get. Other people look at if they have an intern year there, or they have a fellowship there that they may be interested in, so they can avoid moving multiple times. Or if they don't care about moving multiple times, they may be interested, well, where do your residents typically go for fellowships and those sort of things. So all those things are important. You really have to kind of tease out like what is important to you, and in what order are those things important. And then you can kind of work from there to figure out where to apply, and then what kind of things to ask at the interview as well. I would tell you, you really need to prepare to interview. I know interviews are going to be slightly awkward because they're going to be over Zoom or some other medium such as that. but you really need to be prepared to interview. I will tell you up front, every interviewer is different. Some interviewers will talk the whole time and you really won't get to say much, whereas other interviewers will not talk a whole lot and they will expect you to talk the whole time. And so it can be anywhere in between. You need to be prepared to talk. So you need to have questions ready to go, and you need to be the best version of yourself that you can be that day. Okay. Now, it doesn't mean introverts are bad and extroverts are bad. Either one's fine. You just need to be the best version of you that you can be that day, because you are advocating for yourself and you are selling yourself to the program as somebody they want to have in their program. And that is one of the hugest mistakes med students make. They don't really get that. They think that they can just show up for the interview and rest on their scores or whatever, and the program should just love them as a result of that. And that is not really the case. So you are interviewing for a job. You need to advocate for yourself and you need to sell yourself to the program in a way that's believable and not overbearing and annoying, so to speak. So what are some things you can do for that, to prepare for that? Well, you need to prepare yourself to answer questions that you would anticipate getting. We've heard today already a couple things like, be prepared to answer, why do you want to go into radiology? Okay, that's a fundamental question. You should have an answer for that that's ready to go, doesn't sound rehearsed, but ready to go, that you believe is true for you, and you can present and make them believe it as well. So prepare for the questions you should anticipate coming. Now, there are going to be questions you'll get that there's no way you could prepare for. I've heard in the past of somebody asking a question, if you were a tree, what kind of tree would you be? I have no idea what that person would want to hear for the answer for that. And if you don't know anything about trees, I don't even know how you would answer that question. Do they want you to say that you'd be a fruit tree because you're productive, or do they want you to say that you're some kind of hard oak because you're a tough tree? Well, if you don't even know the difference in trees, how can you answer that question? So that's a stupid question. So there are certain questions you'll get you can't prepare for, but the things that are generally you should expect, you need to have questions ready to go for those things. And then you need to have good questions ready to ask, and smart questions. You need to figure out how to be a savvy interviewee. Ask things that are more intelligent to make them know that you actually know what you're getting yourself into, as opposed to somebody that just thinks radiology is a great ratio of not working hard to good money, because that's not what we want to hear. So asking things like, making sure it's a level 1 trauma center, making sure they have a high volume of cancer imaging. What kind of procedures do they do? If you want to go into IR, you really need to know, like, what kind of case mix do they have? How many faculty they have? What is the normal day like? How many tips do they do? Whatever the case is, whatever you're interested in. And you may say, well, I don't know what I'm interested in. Well, you probably know 2 or 3 things you might be interested in and 2 or 3 that you're not interested in. So if you kind of know some things you're interested in, start thinking of questions that relate to that. If you think, well, I might be interested in chest, I might be interested in body, start thinking about some questions that may relate to those things. Like if you're interested in body, ask them, do you guys do transplants? What transplants do you do? What's your referring surgical base? What kind of tumor boards do you guys do? All those kind of things are relevant. And do they have a lot of turnover in their referral base? Do they have a lot of turnover in the surgeons that work for them and so forth? So those are all kind of things that are kind of relevant, and they will make you sound like a smart interview and somebody that really knows what they're getting themselves into and seems to have a plan. So really what you're trying to do in the interview is you're trying to create a story that portrays who you are, what you want to do, and where you see yourself in the future. A story that you are personally excited about and can believe in, and can make the interviewer get excited about and want to envision themselves seeing you fulfill this goal. If you can do that and make a connection with the interviewer and get them excited about you and where you're going, then they may want to take you into the program. If you're just somebody that's sitting in a chair talking to them for 15 minutes, they probably won't be excited about you, and you probably won't be very high on their rank list. So that's sort of what you're trying to do. All right, and then finally, the last thing with COVID, what I don't know this for a fact, but what I kind of anticipate will happen is traditionally towards the end of the interview season, candidates start canceling interviews because it costs them a lot of money to travel. It's just a lot of time to travel and go to these interviews, and they just sort of burn out on it, or they just don't have enough money to keep going. But with this year being a virtual, it doesn't really cost you anything, and it doesn't take as much time because you eliminate all the travel time as well. So as a result of that, I suspect there will be a little bit of hysteria about the whole COVID situation, and probably more applicants will not cancel interviews. So I suspect more students will actually end up doing more interviews in the end than they would have in the past. And as a result of that, probably programs will actually offer more interviews as well to try to compensate for this, to make sure they fill their spots. So I would tell you, it probably would be wise if you get an offer to interview and you accept the interview to not cancel your interview, because you don't want to get left out, because I think there's going to be a lot of hysteria around how many interviews are people going on, what are our odds of matching this person, and vice versa, the same from the candidate standpoint. So probably the candidates will interview more places and the programs will probably interview more candidates. Will it really matter in the end? No. If it's the same number of applicants for the same number of spots, the math is the same. It probably won't matter. It'll probably be a lot of hysteria. But with that said, that's what I expect is probably going to happen. So that's all I had for now, Joey. If you want to open up to questions.
So let me try and get both of you guys pinned up here. Well, and then spotlight video. Okay, so I've got you both up here, and I guess just following up on that sort of topic that you were just saying, there was a question from Trey Brooks that said, you know, given the transition, and he was kind of addressing what you said, with virtual interviews and not having to spend money, there's going to be a lot more people applying to more programs. And do you think that a student should apply to a broader range of programs than they would have before? Or should they apply to a similar range of programs, but just try and make sure that they get the opportunity to interview there? I mean, either one of you all can answer that.
I can go first, I guess, and then Dr. Van Meter can follow up. Or if Jimmy and Wendy want to chime in, go for it too. But yeah, I mean, you might want to apply to a few more. I mean, generally, I know, Trey, I've talked to you about this, but for the candidates that don't know this, most people get interviews based on geography. Like, most programs in this part of the country don't offer people interviews from the far West Coast or the far Northeast or whatever, because they just assume those people don't actually want to come here. And even if we interview them, we'll be really low on their rank list, so to speak. And so the odds of matching them is quite low. So when you start asking me about, well, should you apply to more places, that means you're probably going to start expanding your geographic zone of where you're going to apply. It's not a bad idea, just to realize you're going to get diminishing returns. For the further you go out, the less likely you're going to get an interview from those places. But it's like fishing. You throw the net out there or the line out there, you'll get something to bite eventually. So yeah, you'll probably get some more interviews, but it'll be a diminishing return, I guess is what I'm trying to say.
I agree with what Dr. Spicer has just said. I have encouraged some applicants to apply to a handful more programs, but I think it's also individualized based on your total applicant package. If you're an average to below average applicant, then I would encourage you to apply to more. But if you're in that above average category, then it may not necessarily matter for you. And again, as a program director, we really don't know what's going to happen until October 21st happens. How many applications will we get? How many are interested in radiology? It ebbs and flows. We've been on an upswing lately, but several years ago, we kind of had a decline in the number of applications. But again, with COVID and the inability to travel, less people will cancel. And so I have an overall feeling that we will, there will be the overall number of students interviewing will be more. So I think overall it depends on your application as well.
Okay, and then another question that came up, and I think Aaron Parker answered it for Louisville, but we can kind of address it for UK and add a little bit to it. So is a step 1 score required, or is the COMLEX 1 acceptable? And Aaron had answered that you need step 1 for Louisville. I believe that's the case at Kentucky. Is that true, Paul?
No, we'll take either.
Okay.
I've seen enough COMLEX scores. I know what they mean, but I don't know that's true for everybody else on our committee. So I can kind of translate, I guess, so to speak, if need be, what the score means. And we have several DO students in the program, and actually both of our chiefs this year are DOs, so they can translate the COMLEX as well. So like, I think we have a fairly good idea what those numbers mean. So ideally, we prefer to see step 1, but it's not the end of the world if you only have a COMLEX score.
I know this is some published data through the USMLE, but do you all know what the average radiology successful match, the average step 1 score is?
Off the top of my head, no. I think it was slightly higher than national average, but
okay.
Low 230s maybe. I can't recall. Do you know, Dr. Van Meter?
No, I'm with you. I think it was in the mid 230s maybe, but
yeah. Okay. Let's see. Another question here is, as a 3rd-year student trying to plan for away rotations at the beginning of next year, what do you all anticipate the status of away rotations to be in, do you think we'll be back doing away rotations, and how important are those?
I'll let Dr. Van Meter go first if she wants.
I think it's kind of unknown at this point. That it's all going to depend on the COVID situation. This isn't something that we have any control over now. And how important is it to do an away rotation? I think, again, it depends on your interest in a specific program. And I've encouraged students to do away rotations at institutions that they may not otherwise get an interview, that they would be interested in going to that program. I don't think that doing an away rotation at a certain institution that you would already get an interview at anyway based on your application would make a difference.
Yeah, so I can answer it from my perspective. It depends on your intent for doing the away rotation. If you're just going there to try to learn radiology, then I mean, that's all well and good, but really the main reason to do an away is to see if it's a program you want to match into or not. And it basically gives that program a month-long unofficial interview of you. So if you are somebody that's hardworking and it can make a good impression, it's great, because then the program may really love you and may want you to be there. And if you feel similarly about that program, then your odds of matching may become quite good and much better than if you had not gone there. So for instance, if I don't know all the numbers off the top of my head, but if you look at our roster of residents, the ones that are not UK that matched with us, a high percentage of them did away rotations with us. And we got to know them and they got to know us, and it was just a good fit. So we have a good track record of matching people that do aways with us. Everybody wants to take the low risk person. So if you know the person and you like them, a known quantity is always better than an unknown. So, so if it's a place you think you really want to go and you're a hard worker and you can make a good impression, aways are great. If you just want to go learn radiology somewhere, that's fine. Or if you're lazy and make terrible impressions, you do not want to do away rotations. pretty much the bottom line. So in the track record, we've had 1 or 2 people that made really bad impressions, but for the most part, most people make good impressions. And so it has been a good thing for them and for us. As far as will we have them next year, or we had a few this year, but only for 2 blocks. That was a UK policy. So we only had a couple of ways. Will they be back to normal next year? I have no clue. I hope, but I have no idea.
All right, maybe just to bring Dr. Lee into I'll direct this next question to him. He's our associate program director. So how can a student do well on a radiology rotation, and what should they do to sort of stand out or build a relationship within the radiology department on that away rotation?
No, that's a good question. I think the thing to do is to stay interested. Radiology traditionally, I think, is a tough shadowing experience, even if you're interested in radiology, because it's a little bit, I call it, it's a tough spectator sport. So it's hard to sit on the sidelines and be engaged without kind of, as a medical student, trying to not disrupt the workflow, because like some of our speakers have talked about, we're always working, we're never bored. I thought that was a really good way of saying that we are constantly working during the day. And so it can be sometimes challenging for a medical student to rotate and to make a good impression. I think the thing that impresses me most is that you're engaged and you ask appropriate questions. And I think most of us realize that you're medical students and your level of knowledge should be of just general medicine. And so we want to make sure that you know just the general kind of medical facts that you should know. And if you know some radiology information, that's great. I think beyond just the shadowing portion of it is try to get involved outside of the normal workday. So if you shadow, say, Dr. Owen or Dr. Spicer, talk to them and say, I'd love to do a case report or something. I think both Dr. Van Meter and Dr. Spicer mentioned research, and research is kind of a daunting term that we throw around a lot, but it's really a broad spectrum of educational type scholarly activity to really getting deep down into data mining, and so there's a broad spectrum of what research is. So don't be intimidated by it. Just write a quick case report if you want. But I think that's one of the best things to do, is to be engaged during the day, ask some appropriate questions without trying to be cognizant of the workflow that radiologists are asked to do every day. But also outside of your normal workday, volunteer your time to do something outside of the workday.
All right. Let's see. So we have another question from Madison Crank, and I think the other Dr. Owen is asking to address that question. So.
Okay, well, also everybody can have a chance to answer this question, but for me, this really hit home because I did have kind of an unusual journey towards radiology. So I thought I was going to go into pediatrics. I never thought that I would like radiology. I thought I wanted more patient contact, and so I sort of checked that off the list early on in my medical training. And then I did a pediatric radiology rotation during my 4th year, during December of my 4th year, to help prepare me to be a better pediatrician in the future. And I absolutely loved it. Radiology was not at all what I thought radiology was before I had actually, seen it firsthand. I thought that radiologists were completely isolated. I thought that they had, very little contact with patients and very little contact with other members of the healthcare team, and that was just completely wrong. So as I observed the pediatric radiologist interacting with the pediatricians, doing ultrasounds and fluoro studies on patients and interacting with the patients and their parents, I fell in love with it. So at that point, it was too late for me to enter into the match in radiology. So I withdrew from the match in pediatrics. I took a whole year off, and then I reapplied for radiology the next year in the match. So I absolutely do not judge people for taking a while to make the decision to do radiology. I think that I more judge people on how passionate they are about the decision. And so I find that your passion is much more important than when you made the decision to go into radiology.
Anybody else want to address? The question essentially was, how did you, what was your journey into radiology, and how early did you make that decision? And do you think it's a red flag if somebody, made that decision late?
You probably don't want to hear my story, but I'll just say it's not a red flag. A lot of people come to it late. It's fine. I knew I wanted to go into radiology before I started med school, so that doesn't really, it's not as fun as Wendy's story is.
Well, mine is a little similar to Wendy's, although I didn't have a year off. I was at the end of my third year, early fourth year. I also wanted to do pediatrics. But once I got into my pediatrics rotation, I found out that just was not for me. And I had to do a lot of soul searching to figure out what my story was going to be. Had to figure out what I liked about certain specialties and what my skill set really was. And I started to look into radiology, and I didn't decide until I did my rotation, which was, I believe, beginning of fourth year. So I was a little late, but not too late to put the application together. And again, there is no judgment on when you make the decision, as long as you are passionate about it again and have good reasons and for going into the field. We have lots of applicants over the past several years that have done the same thing Dr. Owen has done, or have, changed their mind late in the game, and there's no one thinks anything about it, because we all understand.
And would you say that would also apply to someone, say, who's a non-traditional applicant who's already in surgery residency, internal medicine residency? Could you address any challenges or barriers they might face?
Sure. We do have several applicants each year that are currently in a residency, whether it be typically at surgery or internal medicine, that want to either transfer or switch specialties. And sometimes those residents just realize that radiology is something that they didn't have a lot of experience with in medical school. And then as a resident, they found out that it's really what they want to do. For us, sometimes the hurdle is with GME, if you've done so many years of a residency, being able to have them come in and have more funding, but that is typically worked out on our end. And then the other thing would be, if you're switching from a specialty, really being honest about why you're switching and having good solid letters from those in your current program supporting your decision.
All right, let's see. So a question from Michael Gerbo. Since everything is kind of virtual this year, how can outside applicants who weren't able to do away rotation, how can they express their interest in the program? And it was kind of a two-part question also. How friendly is UK or Louisville towards couple matching applicants? So how do you express your interest, and how do you all view and work out the logistics of a couples match?
If Dr. Manmeter wants to go first, that's cool.
Okay. The first question about how can you express more interest being an outside applicant, I think always if you have questions or want to just talk about your interest in a program, sending an email or speaking with a program coordinator is always a nice idea. Knowing who you are before your application comes across is never a bad thing, in my opinion. And then how friendly are we towards couples match? We're not unfriendly. We can't see your partner's application. And as long as you are a good applicant for our program, then that doesn't really have a bearing on if we will interview you or not interview you based on if you're a couples match or not. I think the hurdle with the couples match is essentially both programs, kind of where you fall on that list. And how good of an applicant are you and how good of an applicant is your partner for each individual program. And that's kind of a tough thing to answer because we only know your application and we don't know anything about your partner's application.
Yeah, from our perspective, it's similar. If you're not from here or you didn't get to rotate here, it's about conveying to us that you want to be here in an honest, believable way. Some people lie and tell you what you want to hear, but if you can make me believe it, that's great. As far as couples matching, it doesn't change much in terms of where we rank you, unless with the caveat that if you're somebody we really like and are interested in, we will reach out to the other program unofficially and kind of get a feel for where they think about your significant other, or vice versa. They may do that with us first. And if both programs feel like you're somebody maybe in the top, whatever, third of the list or whatever, we may bump you up, each of us bump you up to try to kind of help get you here. But a lot of it's about you have to convey to us that you really want to be here, and then we'll put in some extra work on our end. If you don't ever convey that, then I'm not going to go over and above what I normally do to try to get you here. But if you want to be here, we'll start conversations with the other program unofficially, just to kind of see what they're thinking as well.
All right, a follow-up question to the one about non-traditional applicants. So if you are applying from another specialty, do you have any recommendations for how to sort of improve your chances for matching in DR or improve your desirability to programs coming from, say, surgery or internal medicine?
It's pretty much the same as the other applicant. A regular applicant, I guess I would say, with two caveats. One, I always tell the non-traditional applicant like that's already in training that you need to be a little more aggressive about contacting programs and letting them know you're interested, because I don't want this to sound the wrong way, but most programs tend to focus on the US M4 graduating applicants, the current fourth years. And so the ones that fall into other pools are sometimes overlooked. So you have to be a little more aggressive about contacting programs and letting them know that you are applying, that you're really interested in their program. And then that way they'll actually pull up your application and look at it. Otherwise, it may just sort of sit in a sea of applications that never gets looked at. So that's number one. Number two, you have to have a story that's believable. Why do you want to switch into radiology? If the story is I'm not doing great in my current specialty, that's not a good story. So if it's a truly you want to switch for the right reasons, then that's great. And then if you check all those boxes, then really the last question is just kind of comes down to like the funding issue, like Dr. Van Meter mentioned, and is that something that we can work out internally within our GME here? If all those things are fine, then you're basically viewed like all the other applicants at that point. So, you know, if we interviewed you, so if there aren't any barriers, then we'll rank you like we'd rank anybody else. So.
I'll say something real quick. Also, if you're coming from surgery or internal medicine, for instance, make sure your program director knows your intentions, because we're more likely to reach out to your prior program director to get a feel about you as a person. So it would be very bad if we reached out to your current program director and they said, no, he's applying to surgery as far as I understand. And so, you know, just make sure that that your program director knows that you're applying to radiology. And, you know, if you tell them that you're really interested in certain programs, and it's really good that we hear that from your program director as well. So just make sure everybody knows what you're doing, your intentions are.
And I would say along those same lines, to sort of add to that, just make sure you're still doing a really good job in the residency that you're in as well. Because even if you don't like it, you know, if you still need to do a good job at meeting your responsibilities and functioning well in that residency. So if we do end up talking to the program director and we hear, yeah, this resident kind of gave up on their surgery residency last month, that's going to be a bad sign. So just keep doing a good job at the program that you're in as well.
Yeah, and we want to see a letter of recommendation probably from that program director. So like it was just mentioned, if you start tanking it, you know, we probably don't want you. On the flip side, I mean, there are some more barriers for people who have prior training like that. Not if you're just in an intern year, but if you match categorically, that's a different story. And there may be some additional barriers, but the plus side is, you know, if you're 2 or 3 years into a general surgery residency, for instance, you're going to bring a lot more knowledge to the table than a 4th year med student. So you can be more attractive in a sense because you are more clinically savvy and have more clinical knowledge. And so you will actually hit the ground running in radiology a little bit better. So it's kind of a combination of, can we overcome if there are any barriers, and if not, then you may actually become a more lucrative candidate as a result.
One thing to keep in mind if you are switching or you're a prelim resident looking for a position is be prepared for the question of what are you going to do next year, because if you match that year, you will still have a year off per se because you've completed your prelim. And so be very prepared to answer what you're going to do. We don't like to hear applicants say, well, I think I'm just going to go wait tables for the year. Make sure that you have a plan in place, know what you're going to do to fill that gap with that time.
Okay, let's see, one maybe last question, and then we'll maybe take a few minutes break before we start with the program coordinators. So last question, any recommendation or advice from panelists in how to choose a good preliminary year or transitional program? And should they, you know, is there any difference in preference for medicine or surgery? And I guess that's sort of a rank list question when you're trying to, you know, design your rank list for radiology and think about where to apply. Do you all have a preference? And do you notice any difference from students who come from transitional programs, medicine programs, or surgery programs?
I can go first. So the transitional programs are typically a little bit more cushy and they're a little bit more competitive. So if you are going to apply for transitional programs only, I would make sure that you are a very competitive applicant. I do notice that many residents that do the medicine year or surgery year are a little bit more prepared than doing a transitional year, but I don't have a whole lot of transitional year residents to compare that to. And then in terms of choosing medicine or surgery, I think that if you are very interested in going into interventional or want to do the ESIR program or applying for the integrated programs, then surgery would be a better choice for you. But otherwise, medicine is just fine for diagnostic radiology.
Okay, I can answer this question too. So I would say, first of all, it's okay to do any of them. It doesn't make that big of a difference. If one works out well for you based on your geography, then I think it's okay to do any of them. I would say that I personally did a surgery internship, and I do feel that that was really helpful. And I think that it was probably more helpful than doing a transitional year or a medicine year for a couple of reasons. One, my knowledge of anatomy was a lot better after doing a year of surgery than I think it would be doing one of the other years. And two, I knew what in most of surgery, I knew the post-surgical anatomy, and I understood when someone has had an LAR, what does that mean? When someone has an ileal conduit, what does that mean? And so actually knowing what those things look like, I think was really helpful. And so I do think that surgery is slightly more helpful than internal medicine in terms of preparing you for being a radiologist. I think ultimately you'll be okay either way though. The one thing I will say though is that I think that it's also really helpful to do your surgery or medicine year in the place that you're going to do your radiology training, because you come to know the providers that you're going to be interacting with. If you want to page the colorectal surgeon, you know how to page the colorectal surgeon. You know, if you're familiar with the ordering system, you're familiar with how the hospital works. And so I think that, when I, as an attending now, when I have someone working with me who did their surgery or medicine year at UK, they can actually be very helpful for me even now to know how to contact providers and know where people physically are in the hospital. So I think that that's one thing that is helpful.
Yeah, just to follow up on Wendy's comment, I do think that if they do provide a intern year at where you do radiology, that is very helpful, not only because you can contact the attending physicians, but also you're an intern with a lot of these residents, and you'll be traveling through kind of the residency experience with a lot of these other people. So a lot of our current residents have done either medicine or surgery at UK, and they even have on their telephones, I know that resident, let me just text them and get this story. So that, it just is an added benefit and something to think about. It makes your life easier. And like Wendy said, you kind of bring something to the table as an intern, as an R1, you are already maybe ahead of some of those people that didn't do their intern year at that institution. Not to say that, like Wendy said, also, you're going to be fine no matter where you go. But you can kind of hit the ground running if you've already learned the EMR at that institution.
All right. Well, that I think wraps up most of the questions. Again, thank you, Dr. Van Meter and Dr. Spicer, for participating. I think it's very helpful for the attendees to really get that, more detailed perspective of how to apply, how to be successful, what you're looking for. I think it's all very, very useful information. We're going to take maybe a 5 to 10 minute break, and then we will start in with the program coordinators, and they are going to address, some of the logistics behind applying and what to expect with their virtual interview process. Certainly this is new for all of us, and so there are going to be some unique challenges, and hopefully they can sort of give you a little bit of a heads up on what to expect with those unique challenges that are going to be presented to everyone this year. And I also want to emphasize that the program coordinators work very hard and are integral to this entire process. So, be very thoughtful in the way you interact with them and communicate with them, and use them as a very important resource, as all of the program directors use the coordinators as an integral resource in this entire process. So really, they're a huge asset and a very important part of this. So hopefully we'll get some good insight into how they expect to navigate the process and how they can help you navigate the process that will be starting here in a month or so. So everybody take about a 5-minute break, and we'll get started here at about 12 o'clock. All right. So Kristen Sparks and Aaron Parker are going to be sharing a video that they've done jointly for you all. We will start that in just a minute or two. You can see the video up on the screen here. And then after that, we will do, again, a question and answer session with them as the panelists. Certainly, if you have any questions or any concerns, make sure you get them into the chat box so that we can share those with the panelists and hopefully answer all your questions about the logistics of applying to radiology. With that, I guess it's a little bit after 12, so we said we'd start at 12. So let's go ahead and we can start right now. So we'll give it over to.
Hi, I'm Kristen. I'm going to go ahead and play the video. It does have sound and speaking, so if you can't hear it, please let me know.
Kristen, I'm not sure that the audio, is there audio already?
Yes, there is. 1 second and let me see how to make it play for you all.
I think under the screen sharing option, you should see an option to share computer audio as well.
Let's see. Share computer sound. Okay, I'm going to try again.
All right.
The last several months have been a change for everyone in medical education as a result of the pandemic. The usual recruitment methods and norms are moving to a virtual platform. While we can't replicate an in-person experience digitally, you should still gain the same knowledge about the program. The ARIS timeline has changed this year, but all other factors of the application process remain the same. Applicants can start to apply September 1st, and programs will be able to start reviewing applications on October 21st. Keep in mind, any applications submitted after October 21st will be date stamped in real time. We have compiled 9 tips for you to consider for the upcoming interview season. We strongly recommend testing your technology beforehand. Make sure you have updated software and a strong internet connection. Practice with a friend to make sure your microphone is working well. Be prepared with phone numbers so you can quickly transition to a voice call in the event that your computer or internet connection fails. Spending the time practicing with a friend will give you valuable feedback, such as, are you speaking too quickly? Tip number 2, arrange your space. Organize the room so your camera does not show anything you do not want the interviewers to see, such as a bed or a bright window. Turn off the camera between interviews and during breaks so that you're not highlighting an empty chair. Also be sure to pay attention to your lighting and different camera angles. Ensure a quiet location. Try posting a do not disturb sign on your door. Check with your school to see if there are designated spaces with good lighting, strong Wi-Fi, and soundproofing. Take advantage of these spaces. Tip number 3, limit distractions. Be sure to mute your phone and computer alerts and avoid multitasking during the interview. Block plenty of time both before and after the interview in order to be on time and stay present for the entire interview. Consider taking the entire day off to minimize distractions. Keep in mind that personal mannerisms, such as scratching your head or your face, adjusting your glasses, or fixing your hair, might become more noticeable when you're being viewed on camera from the chest up. These simple movements can become distracting. Make sure you're making eye contact by looking directly into the camera rather than at the computer screen. Some devices allow you to move the video thumbnails on the screen to just under the camera. Mounting the camera device at the eye level keeps you looking straight ahead, so you and your interviewer see each other in a horizontal plane rather than looking up or down at each other. During individual interviews, you do not need to mute yourself, which can introduce some awkward pauses into the conversation. However, during group interviews, it might become necessary to utilize the mute-unmute buttons for large groups. Tip number 4, prepare for each interview. Review program websites before your interview. Programs often have commonly asked questions listed on their website, which will save you time from having to reach out individually to each program. Make a list of questions specific to that program and have them ready to ask during your interview. Contact current or past residents to gather their perspective on the program, the training institution, and the city. Have your application materials ready in case the interviewer asks you information, and you can easily pull them up and share them on screen if the situation arises. Tip number 5, act professionally. Take the virtual interview at least as seriously as you would in a face-to-face interview. Appear to dress professionally and be well-groomed, the same as you would for a face-to-face interview. Do not eat, drink, chew gum, or walk around during the interview. Make sure you're on time. Make sure you're also demonstrating professional body language. Nonverbal cues are especially important during virtual interviews in order to connect with the interviewer. If you're participating in a group interview, be mindful of sharing time with others involved in that interview. Convey your responses completely and concisely. Tip number 6, building rapport. Be sure to say a proper, friendly hello to your interviewer. It's appropriate to smile and to also use a moderate number of hand gestures. Demonstrate that you're interested in your interviewers. If you are familiar with their work, consider asking them a specific question about their research or their interest. Say something complimentary about it, but only do this authentically, not just as a form of flattery. Tip number 7, follow up. Send a thank you card or a thank you email to each interviewer. Many coordinators provide contact information to applicants up front. Look through the program materials thoroughly. If you offer to send some additional information or materials to an interviewer, be sure to do that as soon after the interview as possible. Tip number 8, cancellation courtesy. If you accept an interview invitation and need to cancel later on, you need to give programs a couple days notice, just like you would as if it were an in-person interview. Give the program an opportunity to fill the open interview slot with another candidate. The goal is to put your best self forward and exhibit professional behavior. Down the road, you may end up applying to fellowships in the department, and you don't want to be remembered as the candidate who canceled the morning of a scheduled interview. Tip number 9, letters of recommendation. Inform your letter writers which specialty application you are using their letter for, especially if you were recently undecided and considering a couple different specialties. You don't want your letter for radiology to mention your goals of getting into dermatology, for example. We have compiled a list of common interview platforms that you may encounter. Try to familiarize yourself with these platforms. Common ones include Zoom, Microsoft Teams, BlueJeans, and Thalamus. For additional resources, we encourage you to explore the AAMC website. The University of Kentucky and University of Louisville coordinators are now available to answer any questions you may have about the interview process.
All right, that was great, guys. Really nice setup. And so let's start. I've got both of you all spotlighted here, and we can see if there are any questions. I haven't seen any come across, so let me just say, and you address some of these in your tips, but say you do encounter a technical difficulty in the interview. What do you all recommend sort of as your first step how do you recognize that there's a technical difficulty, and what should you do to try and address that?
Erin, do you want to go ahead? You can start. You can answer first.
Hi, good morning. I would first make sure you're communicating to the interviewer that there is some sort of technical issue going on, because perhaps it's not happening to them. So just that way they realize that you're kind of putting the interview on a pause for a moment till you can work out the issues. And then you might, depending on the platform, you may need to possibly exit out of that particular interview and try to rejoin, whether it's in Zoom or Microsoft Teams, and see if that resolves the issues. Most likely that will resolve that issue. If you tried everything and just are having, endless computer issues, I would make sure to have the phone numbers, which the coordinators will provide to you in the event of technical difficulties. Have those ready so you can quickly just make a phone call and continue the interview that way, because you don't want to delay the interview too long trying to work out those issues and keep the schedule moving so you can get on to your next interview, because you'll likely be interviewing with 3 or 4 different faculty members for that specific program.
Yeah, and definitely do not be shy to reach out to the coordinators and let them know. I know University of Kentucky, we're going to be using Zoom probably for our interviews, and it's sometimes hard to see when people pop out of breakout rooms. So it's very important that you contact that coordinator as soon as your technical difficulty happens so that we can get on it and fix it.
Another question. So when and how will applicants know when they get an interview, and how much time do they have to sort of respond or accept that interview? How quickly does that process happen?
I know. Go ahead, Erin.
Oh, no, go ahead. You can start.
Well, I know for the University of Kentucky, the time in which you'll get an interview invite sometimes varies. It could be it could be a week, it could be a little bit longer. We send invites via Interview Broker, and then through that you'll pick your interview sign-up date or your time and your date. I know this year going virtually, we're going to probably be doing morning sessions and afternoon sessions, so there'll be a lot of variety that you'll be able to sign up for, but that's typically how we do it at UK.
At U of L, the last few years, we've used the platform called Thalamus, and we're planning to probably use that again this year. In terms of the application interview invites going out, so we have on October 21st is when we will get those interview applications into us to be able to review. It usually takes us about a week to be able to look through the bulk of those. This year, again, as we've mentioned earlier, it's a little bit of an unknown in terms of how many applications we'll receive compared to prior years because of the differences with COVID going on. But usually within a week or so, you'll start maybe to see some first round interview invitations to go out. And nowadays, a lot of that's automated. So once you get an invitation, you can self-schedule, whether it be, Interview Broker through Eris, Thalamus. You can see the available time slots and pick the date that works best for you. So that happens very quickly in terms of once you get that invitation in your inbox, you can, schedule almost instantly if you want to do that.
And I know from being a sort of advisor to medical students going through this process in the past, those interview spots can often fill up very quickly. So I would encourage you to have your notifications turned on your cell phone so that when you get an email that week or two after October 21st, you're on it, because I know that with a lot of programs, there are limited interview spots compared to, how many people are applying, and those spots can fill up quickly, although there may be more flexibility this year with the virtual interview. A question that Dr. Oates posed, do you all have a sense of, in your program, are you going to be doing multiple one-on-one interviews and sort of rotating through, or will there be an individual interviewing with multiple faculty, or a mix of both?
At U of L, we wanted to try to make the interview day experience as close as possible as what we've done in years past. So that will include, in our situation, you will be meeting with 3 faculty members individually. And then we always include our chief resident as an individual interview as well. So there'll be 4 one-on-one interviews. And then new this year, to try to give applicants the opportunity to speak with our current trainees, which in the past was done either in the form of a pre-interview dinner or as a day of lunch. We wanted to replace that opportunity, and we're going to have a small group of our current residents conduct an interview in a small group forum as kind of the replacement for the pre-interview dinner.
Here at the University of Kentucky, we will be doing pretty much the exact same thing. We will be doing 4 one-on-one interviews that you'll rotate through the 4 interviewees, and that will include our program directors, some faculty members that are on our resident selection committee, and our chief residents, one of the chief residents. And we'll be doing a group, in place of like a resident lunch, we'll be doing a group forum with our residents as well.
All right. Another question that had come up is, will there be an opportunity to arrange a visit if a student is really interested in attending the program and wants to come see the city or have some face-to-face interaction? Is that something that is possible for a student to do during the interview season?
I will say probably not something that will be coordinated through the program or through the coordinators. If a student is really interested, they could maybe reach out to a former resident or a current resident and ask them any questions. But I don't think that it would be anything that would be coordinated through the program.
I would agree with that. If you have specific questions about the city itself, I think any coordinator would be happy to share, thoughts of places to go to visit if you want to make a trip on your own just to do, some exploration of the city. But in terms of coordinating a visit within the department, just because of this year with COVID and all of the regulations with social distancing, we won't be allowing visitors into the department. But certainly if you want to reach out to a current trainee, they may meet you after hours on a personal basis to give you, more information about the program, or if you want to explore the city. But as far as a departmental organized visit, that won't be happening this year.
All right. Let's see. I don't have any other questions. Let's see. Is there somebody out there who has a question for chat, or are there any other things that you guys would like to clarify, or something that you think is important tip for how to communicate? I guess I can ask, what's the best way to communicate with you guys? So if there is someone who's confused about the process, is it easier to give you a phone call? Is it easier to email you? What's the best way to follow up, to sort of ask additional questions or work your way through the logistics?
I think this will probably vary coordinator to coordinator. For me personally, before or after the interview, email is probably going to be the easiest way. But if it's the day of the interview, I would definitely encourage picking up the phone and giving me a phone call. I know that we're readily available to answer our phones on those days. We're expecting questions from interviewees, and I think we're ready to answer them via phone.
Yeah, I agree exactly with what Kristen said. The day of, probably phone calls the best, because that's what usually more urgently we respond to, but emails also checked it frequently. So definitely reach out to us. Coordinators are excellent resources, and don't hesitate to take advantage of getting information, or we can help you troubleshoot any issues that could arise as you go through the process.
Okay. Do you all know whether interviews are going to be predominantly offered during the weekdays, or will there be some weekend interviews offered, evenings, mornings, afternoons? What's the general schedule going to look like for the interview process?
At U of L, we're doing only during business days during the week, during normal working hours. We will have AM sessions and PM sessions.
And pretty much the same for UK as well. We're only doing Monday through Friday, and we'll have a morning session and an evening session, or afternoon, evening.
And how long will the process be start to finish for like one person's AM session?
I would say 3 to 4 hours.
Okay.
Yes, same here.
And will candidates have the opportunity to attend a noon conference? I know that's something that they've done in the past.
At U of L, we are not incorporating a new conference as part of our interview day. We didn't in the past in our in-person interviews, so we're just kind of trying to replicate as close as possible what we had done previous years.
At the University of Kentucky, we used to incorporate the noon conferences in. However, this year we're not going to incorporate our noon conferences in our virtual interviews. So that will be a change up for us, just because we're trying to do a morning session and an afternoon session.
Do you know approximately how many interviews will be offered? Is that information that's publicly available or not? And will the interviews that you're offering will you offer more interviews than in the past?
So I'm going to say at the University of Kentucky, we will be offering more interviews this year, but also matching with residents this year than we have in previous years. It's not necessarily due to COVID. We may inflate a little bit due to COVID, but we're also matching with more residents this year. So that will be part of our increase.
At U of L, we usually don't advertise how many interviews we do every year, but I will say this year, because of COVID and all of the unknown factors, and we are adding an extra interview day to our normal cycle. So overall, we will be interviewing more applicants just because of some unknown factors about the expectation possibly of having more applications coming in. We've added an extra day for some additional slots.
All right, a question from Trey. Do you have a sense of whether or not there's going to be any coordination between programs that are interviewing for the radiology residency and, same institution transitional programs or surgical programs? Is there any coordination between those two interviews, or are those totally separate?
At University of Louisville, it's a completely separate process. So you'll get invitations from internal medicine, for example. You have to apply to them as a separate program. When it comes time to the rank list, sometimes programs will reach out to each other and just kind of touch base and identify the certain candidate maybe in your top third or something like that. Just to kind of coordinate a little bit that way. But other than that, it's really operated totally separate. We never see their rank list. They don't see our rank list. Just in very general terms, we may get a phone call just about, top third or top half type thing. But other than that, it's completely separate. Their interview days are different than ours, and they may run their interview process a little bit differently as well.
Same for the University of Kentucky. We have no formal match with preliminary programs. I will say we do have a very good relationship with our prelim program coordinators. And oftentimes, if they know that an applicant in their program is also applying for radiology, they will reach out to us and ask. Sometimes it falls through the cracks, though, and it's great when applicants email me and let me know that they are applying to a preliminary program at our institution, so that I can reach out to those coordinators and let them know we interviewed this applicant as well.
Any other questions from the attendees out there? Give y'all a little bit of time. I'm trying to think of any other logistical questions I might have. In general, I guess for residents who are trying to contact the program, or if they're doing an away, med students who are doing away rotation, should you all be the primary contact, or should they talk with one of the program directors directly? What's the best way to establish sort of a line of communication and begin to express your interest in a program?
So I would think maybe a little bit of both, contacting the coordinators and letting them know they're interested, but also contacting the program directors. I know we have a great relationship with our program directors, so if there's someone that's contacted us often, we will mention that to our program director, and sometimes they'll say, oh yes, they've contacted me as well, but sometimes they've never heard that the person contacted them. So I would say probably reaching out to both of us. I know that I coordinate the medical student electives here, so I know a lot of the students that are interested in applying to our program. So it's important to let us know if you're interested in radiology as well.
Yes, exactly the same here in Louisville. You could reach out to either the program director or myself. Coordinators also, we work very closely with the program directors. I also am involved with the medical students at University of Louisville, so I'm pretty familiar with the students within our institution that are interested in radiology. But definitely reach out to the coordinator. I think either avenue is fine. Coordinators usually keep pretty good track about students that are on the radar that are interested in applying to the program. So that way, when it comes time for the applications that come on October 21st, we already have an idea of some names that have reached out to us about interesting questions. So we know that, you know, you're really looking at possibly relocating and looking at the program strongly.
All right, good deal. Is there anybody else before we start to wrap up this part of the webinar that has any additional questions? They can really be about any topic that we've addressed over the course of the webinar. Here's one. So is it acceptable to send an email to the program director and then sort of CC the program coordinator, or would you prefer that they be separate emails with separate communication?
I would say yes, that's an absolutely acceptable way to send an email to the program director and then copy us in it so that we both get the message.
And where's the best place for somebody to seek out your contact information or to seek out the program director's contact information?
I know for the University of Kentucky, you can Google our program and my contact information will pop up. It's very easy to find professor's contact information as well. And if you can't, then you can always email the coordinators and we can give you the program director's contact information.
Yes, we have our contact information on our program website as well. So it's pretty easy. Just Google University of Louisville Radiology and it should pop up.
All right, so there's a few different questions starting to pop up. So let's see, first of all, will there be more virtual events? I can kind of answer that. We are gonna actually be holding another virtual event about 1 o'clock where we're gonna be in much smaller groups, maybe one attending to 2 or 3 medical students, and you'll be able to ask, you know, questions about our experience, why we go into radiology, how we navigated the process ourselves. So I'd certainly encourage everyone to participate in that. This will also be recorded. So if there's anything that you forgot or don't remember, we are going to try and make this available publicly. And that could also be spread to a friend or someone else who might be interested in radiology. Then a question from Cole Wilkins is, as far as writing thank you notes after the interview goes, do you think it's better to reach out via email? Or is it likely that they'll give you the contact information that's preferred, whether that's an address or an email?
So I know for us, we include the contact information on the itinerary. I don't think there's a preference. I think it's a personal preference, whether it's email or an actual thank you card sent to the interviewer. So you can do either way, would be fine.
Yes, either way is fine. I know for our program, I do provide the contact information, snail mail if you want to go that route. Either way is fine. A lot of times, if people are doing the snail mail, they'll put all the cards in one big envelope and address it to the coordinator's attention, and then I will distribute those individual cards out to all of the people they sent them to.
Okay. Another question was how to contact people about updating their application. So if a step 2 score comes in, if they have a new publication that comes out in a journal, what's the best way to contact people and who's the most appropriate person to contact?
I would say for updates,
No, go ahead.
updates to applications, I would send that to the coordinator, especially if you're kind of in the height of the interview season. That way we'll make note of that and draw it to the attention of your interviewers to let them know if you have a new abstract accepted or something of that nature that you don't have reflected on your CV that was uploaded in ERIC. We can definitely draw that to their attention. Or if you have a new USMLE score, we can go and grab and draw that also to their attention. If you have like step 2, for example, that came in that wasn't there when we did the initial run through of the application, we'll point that out to them.
Okay.
Yeah, I would agree. I would
go ahead.
I would definitely say send it to the coordinators because not just program directors are going to be interviewing you. So we'll make sure that it's distributed to everyone that's interviewing you that day.
In terms of trying to express interest in the program, do you think expressing that interest, what's the appropriate timeline? Some people are saying, the question really says, should I go ahead and reach out to you all or the programs that I'm interested in, or should I wait until I've submitted my ARIS application and it's released on October 21st? When's the most appropriate time to start to establish that communication and express interest in the program?
I would say go ahead and start expressing that interest before you apply so that we can go ahead and have your name on the radar to look for when the applications come in.
Yes, I agree.
All right. See, any other questions from any of the attendees? Well, if there's not any more questions from the attendees, I am going to go ahead and share the link. I'm going to have to pull it up here, but I'm going to try and share the link for the upcoming speed mentoring session. That's going to start in about 27 minutes to be very precise. Let me see if I can get.
While Joey's picking that up, can you hear me?
Yeah, we can hear you.
I would just encourage all of the attendees to be very kind and respectful to our program coordinators, just as a, advice to what Dr. Spicer said earlier, putting your best self forward. Very rarely do we have some medical students who maybe treat faculty one way, but then treat our program coordinators another way. And that's a big red flag. So just good advice to you when you do these interviews. Treat everybody the same, and especially treat our program coordinators really, really well because they keep us going. So we really, really appreciate that.
Absolutely. I have actually heard similar horror stories from different programs. So you don't want to be, you have to realize that Aaron and Kristen are as integral to the process as Dr. Spicer and Dr. Van Meter, and their opinion matters very much to all of us. So make sure that you're cordial and respectful to everyone. And that should just be true in life in general. So not just when you're going through an interview process, right? All right. Well, I want to thank everyone for coming. I just posted to the chat the Zoom link for the speed mentoring. Again, we're going to be using breakout rooms. We should have about 8 to 10 mentors, and that should be roughly 2 to 3 medical students per mentor. So hopefully it'll be a good session where you can get some additional insight and ask some additional questions to why we did radiology, why we're passionate about radiology education, and why we're really, in academic medicine, but also hopefully we have insight into what private practice might be like or teleradiology might be like, because a lot of us have worked in multiple settings. And we should also have a number of different subspecialties represented. So we'll have breast radiology, abdomen, ER, interventional radiology. So hopefully we'll have a broad spectrum of people that you can get some insight from. And so I hope to see everyone at, let's see, someone's saying the link didn't come through, but I hope to see everyone at 1 o'clock. Let me try and send the link one more time. Anybody, is that link coming through to everyone? Do you all see that on the chat? You may have to click the chat. Okay, perfect. So yeah, so I look forward to seeing everyone again in about 25 minutes. So take a break, relax, and we will reconvene. I think this was a pretty good success. I hope everyone got their questions answered, and I really appreciate everyone, all of the panelists' time for taking this Saturday afternoon and making this all go very smoothly. And I hope that we can, continue this in future years. And with that, we'll go ahead and end the webinar. Thank you.